Right, why don't we get started? Good afternoon. My name is Dr. Joan Reed, and I want to welcome you to today's session, Interviewed While Black, which is brought to you by the Harvard Medical School Office for Diversity, Inclusion, and Community Partnership with Harvard Catalyst. The interview is a critical step in the recruitment process throughout a physician's training and professional trajectory. Yet we're aware that implicit and explicit bias can operate during the process. Bias that can unfairly disadvantage Black and Brown applicants, hindering the advancement of well-qualified candidates, while at the same time limiting our medical community's access to excellent trainees who can contribute to the success of our organizations, while also increasing diversity and inclusion in academic medicine. Today, we've invited 4 of our colleagues who recently published an article, Interviewed While Black, to speak about this issue, their own interview experiences, and how our academic medical community might address the problem. And let's start with our first, one of our first participants or panelists. Dr. Ellis is a current medical education fellow in the emergency department at Beth Israel Deaconess Medical Center and Harvard Medical School. Adara Landry is an assistant professor in emergency medicine at Harvard Medical School, assistant residency director for the Harvard affiliated emergency residency programs, and co-chair for the Diversity and Inclusion Committee for the Department of Emergency Medicine at Brigham and Women's Hospital. Dr. Alden Landry is an assistant dean here at Harvard Medical School in the Office for Diversity, Inclusion, and Community Partnership, also an assistant professor of emergency medicine and an emergency medicine physician at Beth Israel Deaconess Medical Center. And Dr. Onyeka Otugo is a health policy research and translation fellow and emergency medicine physician at Brigham and Women's Hospital with an interest in health policy, racial health disparities, and access to care issues. She's also a Massachusetts Leadership and Advocacy Fellow and is John F. Kennedy and Adrienne Ching Fellow at the Harvard Kennedy School of Government, where she is a Master of Public Health Administration candidate. And to get started with our first question, I'd like to put it to Dr. Ellis. Black candidates can sometimes feel like token minority during the interview process, and in fact, can sometimes find themselves the only person of color in the interviewees as well as the interviewers. What are some of the conditions that might lead an applicant to feel like a token minority?
Hello, Dr. Excellent question. Tokenism actually, as defined, is a performative or perfunctory strides at diversity and inclusion as opposed to a full-on support for what it brings to the program. And so it kind of goes back as far as early the 1940s and 1950s when a lot of the movie industry was starting to integrate, and a lot of these characters would be brought into the movie. And the classic joke and the way it was popularized is the token minority, or the person who would die first. And I would liken that to kind of the experience when you're into higher education, in that it's more about what's on the back end, applying a lot of support, a lot of community for the individual who will be coming in as an underrepresented minority in medicine, and most certainly additional resources. Tokenism kind of been going, can cause a number of different, in terms of having the minority applicant not feel comfortable about the program. So having some of the things that brings tokenism on the plate, such as the minority tax or a diversity tax, and understanding what that is and how difficult it is for a minority applicant to be in a situation where they're asked to do additional resources or bring additional time and commitment to a mission without having any ability to have support and control. So,
have you ever experienced a sense or feeling of being a token?
I most certainly have. I'm from the University of Houston, and I've also been part of Howard University, but also the Mayo Clinic. And so 2 of those institutions were not historically Black colleges or universities where I would feel the full comfort of it. But I think also those 2 institutions have been fairly formative. But I've been in interview settings in which I didn't get the same feeling in those two predominantly white institutions. And um, it's hard to always distinguish in which a program can do to make you feel like you're supporting the diversity and inclusion for a program as opposed to tokenizing a minority. And a lot of it has to do with just the comfort within the interview setting. And so I've certainly felt in a number of interviews being a minority and having the concern of tokenism for sure.
Are there others on the panel who had a sense or feeling of being a token or treated like a token?
Yeah, of course. I think we've all been in that position, especially in academia. The higher you go, the fewer and fewer minorities that you see. And many of us have the benefit of coming from HBCU backgrounds, and that is a much different experience than transitioning to academia. Even here at Harvard, there's spaces where you walk into the room and you're the only minority in the room. And then some of us, carry other identities, and with those intersectionality components, we often are sometimes double or triple minorities in walking into certain spaces. I don't think this is uncommon. I think all of us can share stories, and I think this is part of the reason why Dr. Landry and Dr. Ellis led us in the writing of this article. It's just because of how much we've had these experiences along the way with every step of our promotion through in academic medicine.
Thank you.
One thing I might add, if that's okay, is when it comes to recruiting someone, because you want to create, let's say, a diverse task force, I can imagine someone feeling uncertain of whether or not that recruitment will be viewed as tokenism. So one thing that I advise is trying to recruit people with purpose and understanding what value they will bring to the team. So an example that might be positive is you're looking for someone to join, let's say, your ultrasound research group or your toxicology research group. And you say, well, right now we don't have diversity. Let's try to find someone who is an expert in this field. We'll bring them in. We'll make sure they feel integrated into the team. And we'll try to add in diverse perspectives. And this person will be an expert or a budding expert in this field. That to me makes it seem like there's some purpose behind it versus we need diversity. Let's just get any person who is not interested in this field, but they satisfy a checkbox, meaning they're a minority, they're a woman. Granted, they're not interested at all in this industry or this area of practice, but they will make us look like we're diverse. Two different fields here. And I think it's important to be transparent and with yourself and with your team as far as why are we looking for diversity? What will they add? What can we bring to them as well?
I think part of what I'm hearing and what you're saying is what candidates want is to feel that what they bring that's special and the excellence that they can bring to a program is why they're being sought and why they're being interviewed, and not because of a feature that they bring with them. I'm going to follow up with you also, Dr. Landry, that we know that some of the most accomplished individuals can sometimes get this experience or feel like they're imposters, something they call the imposter syndrome. And particularly for women and for people of color can be susceptible to this phenomena. Can you tell us a little bit about what that means and what factors within an interview, a department, a school, in these settings can foster those kinds of feelings?
Yeah, so I think most of us are familiar with the concept or the phenomenon of imposter syndrome, and it's been most frequently described in organizational behavior or psychology literature. And a lot of our research comes from there, but there are a lot of narratives and stories and shared experiences that come from all fields of practice, such as medicine and education. And we often describe it as this phenomenon or feeling where high achievers really struggle to internalize their own success. They have a hard time accepting their worthiness, that they've earned the work that they have achieved, that they deserve it. And even though it's very common, many of us don't feel quite comfortable speaking about it in real time for fear of being found out, as someone might discover, oh, maybe I am actually a fraud. And so it was first discovered in the 70s by actually two women psychologists. And if you go back and read the paper, which I highly recommend folks who are listening to this to really go back and read the original work related to imposter syndrome and ask yourself, do you feel like you fit into that original definition? Because who they were studying were actually 20 to 45-year-old white women who were mostly white women who were mid to upper class women who were actually externally very well praised. They had received a ton of honors. They had high SAT or standardized test scores. They were well recognized and applauded for their efforts and their accomplishments from the external environment. But internally, they struggled. They felt that they were fraudulent. They felt that all their success was due to luck or a fluke or their looks or charm, but they had a hard time believing that what they had accomplished themselves was because of their own inner capabilities. And the psychologists looked at why this was the case. And they really thought that it was probably from the early onset of familial conditioning, where parents might have really tried to raise their kids to believe one of two things: either my kid is a genius, and then the kid struggles to live up to that expectation, or the kid wants to be seen as successful and having a lot of potential, but they actually are neglected from being seen that way by the parents. I think what happens is in that paper, they talk a lot about women. Later on in research, we see more evidence coming out that actually imposter syndrome is found sort of equally within the sexes. Those original authors come back and write another piece about, okay, yes, men and women experience imposter syndrome equally, roughly. But what we don't ever see is a lot of evidence or a lot of support about how it's so different for minorities, for Black students who experience this feeling, and what is the original cause. And it's not until much later we start to see research that the education environment, that the schooling system really has differential treatment for Black students versus white students. We've seen this in published papers that students at a young age, even preschool, elementary school, are disproportionately punished and disciplined when they're Black compared to the white students. This creates this environment that the culture I'm in right now in this education workspace is unwelcoming, is toxic. For whatever reason, doesn't see my value, I'm easily dispensable. And that continues and propagates in different ways, through undergrad, through medical school, through residency. We find all these external sources that really make us feel like, actually, this environment is not welcoming to me. And it's less so about just my own inner feelings, but we're also reflecting all of these sorts of institutional and structural occurrences that really change our self-value, our self-worth, the way we monitor our progress. And so the idea of imposter syndrome is quite complex when we think about not just all of us, but Black students who have really struggled throughout their entire progress. That journey that they have taken is much different from as early onset as even elementary school.
Give some examples of what kind of factors in an interview, say in a school or hospital, coming for, say, residency interview or medical student interview, that might foster those kinds of feelings.
You know, I think there's some superficial things that we see where it comes to, when you meet someone and you hear about all their accolades, I'm the director of this, the chair of this, and this and this and that. It can really make you feel like this environment is very fruitful for someone like you. But I'm not seeing anyone around who looks like me, who's been able to accomplish that same success. It's very basic. And it's just a matter of solving that discrepancy where we can have someone who looks like me demonstrate that success is possible in this environment. And so sometimes the imposter syndrome is, yes, I internally feel like I might be fraudulent, but also it could be this place here will see me as someone who maybe slipped through the cracks, who was given some sympathy vote or sympathy invitation. And so it's just much more complex than I look at awards on the wall and I'm nervous I won't be able to achieve that.
So what I'm hearing from you, I was talking with asking Dr. Ellis about, you come for this interview and you don't see other potential candidates or interviewers that look like you. But I'm hearing from you, Dr. Landry, it also maybe when I walk around this building, I don't see any images on the walls, or I don't see representations in leadership or the people who are held in high esteem that look like me.
Exactly. And I think there are some things that we can do to try to help mitigate it. If you look at the original research on imposter syndrome from the psychologists who really own a lot of this space, they're thinking solutions are related to therapy, because a lot of people have these ingrown, engraved feelings about themselves that manifest as anxiety, as perfectionism, as depression. And so a lot of the literature in that space, they treat imposter syndrome with therapy. We cannot do that in an interview session, right? Like I conducted 8 interviews today. There's no way I could have provided therapy for my candidates. But there are things that I can do, such as remove this feeling that we are a perfect system. So I openly speak about the problems that I have had, all of my personal struggles, the problems with our institution, with our field, with our program. I mean, you have to kind of normalize this idea that we should not strive for perfection. I also really want to try to give them as much praise as I can. So I love to read letters of recommendation, say, look at what everyone is saying about you. They think that you're worthy of where you are right now. I hope you know this. It really is a shame that we keep letters of recommendation private, because I really do think that it's a nice way to show people that everyone around them is in support. There are other things that we can do, such as putting people together. So it's nice to have Black interviewers meet the Black students, because then they can really understand this common experience, such as, is this an environment where I will fit in? Is this an environment that's toxic or really nurturing for someone like myself?
Thank you. I'm going to move a little bit from here to talk about another thing that's often written about in the literature, and what part of what the 4 of you wrote about. And it's turning to this issue of microaggressions. And do they play out? Have you yourself experienced or heard of others who've experienced microaggressions during the interview process? And what does that mean for the interviewee? Dr. Tuko?
Hi, yeah. So microaggression starts the minute an interviewer picks up a file and looks at the applicant's name, whether it's like the face that they make when they see an unfamiliar name, them scrunching their face after an applicant tells them the meaning of their name or words, the origin of it. And it kind of continues throughout the day. So there's aspects during the interview, such as let's say the interview is blinded, if an interview is asking a particular applicant what their scores are. So things like that all kind of play a role, and kind of like talks to what Dr. Landry said about imposter syndrome. If an interview is their first question is asking me what my scores are, they're basically saying that I shouldn't be there, more or less, or how did I get here? And then another way it kind of plays out is like when people ask you questions such as where you're from, and you tell them, like for me, for example, I would say I'm from Maryland, and they're like, no, where are you really from? Because they have a personal interpretation of what it means to be an American, and you don't look like that to them. So at the end of the day, it kind of leaves the applicant feeling like they don't belong there, and kind of continues those feelings of imposter syndrome, and then they leave the place, like whether or not this is actually a good fit for me at the end of the day. So.
Right. For you, but for others, about what is the impact of this on the recruitment process in terms of how people feel in the meetings and after?
Yeah, I guess it kind of starts off with the kind of definition of what a microaggression is. People often associate with a micro with it being small and not having as massive as an impact as something like being a microaggression. However, a micro and a macroaggression can have long-term implications for an interviewee, for a resident, for a physician, whoever it might be. So it kind of starts off with you understanding what the weight of a microaggression is. So when someone experiences it at the time, they might not address it right then because they're still experiencing the shock of what just happened. And they might not start processing it until days, months, years later. And then at the end of the day, they're left with anxiety. They could be depressed, feelings of imposter syndrome. So just kind of understanding that the weight of what a microaggression is to an applicant, and then also understanding that sometimes microaggressions can be unintentional. So you could say something not realizing what the impact of it is on whatever the particular applicant may be. So, and that being said, like I mentioned, it can impact the overall impact of your ability to recruit a diverse class. It can impact your overall institution's ability to recruit individuals that are diverse in terms of residents, medical students, fellows, and physicians and those into leadership roles. So kind of taking a step back and understanding what the long-term impact might be, and then taking ownership of your comments and how they might impact potential applicants, and then kind of bringing in the importance of being an upstander versus a bystander when you do experience situations like that, and saying something when the applicant faces that.
Can you describe what you mean by upstander versus bystander?
Yeah, so a bystander is someone that kind of takes the passive approach. It's like, oh, I heard something that wasn't right. Versus an upstander, when they do see something like that, they kind of confront the situation head on there. It's like, hey, I heard what you said to so-and-so, that wasn't right, and these are the reasons why it's not right, and these are how we can address these issues later on.
Thank you. I'm going to put part of this out to everyone, because one of the things we're talking about the interview process, and particularly for us now as it relates to residents, but it could be through any interview process. And you alluded to part of this, that the microaggressions, although it may feel like it happened at that one moment in time, it can come back. But I would say for most Black and Brown individuals, they've not experienced one microaggression. It's sort of cumulative. And what is that cumulative impact? And could some speak to that?
Well, I think Dr. Otugo and Dr. Landry already mentioned this. If you're starting to sense that as you're in the interview process, when you recognize that you're the first, you're the only person of color in the room, and then your first interactions are negative, and that imposter syndrome starts to build. That's easily how trainees or applicants will put those programs lower on their rank list when it comes to the actual rank process for residencies. And so I think that you have to be really proactive in this space and making sure that the trainees or the applicants are comfortable from the very beginning. And I know Dr. Landry mentioned some affirmative efforts that can be done. But I think there's also some words or commentary that should be just removed from the application and from the interview process. When you tell a student, oh, you're different than our other applicants, that automatically is going to embed some imposter syndrome. So don't bring that into the commentary. When you say, oh, we don't typically get applicants from your school, that automatically starts to bring in some of those layers of imposter syndrome, which can be felt in the form of microaggressions by some, and again, make people not want to be in that place.
So I'm going to ask a slightly different piece, because it's not really directly related to your article, but I think it's also important as we think about these residents, these trainees, or our future faculty and others. What is the impact? You talked a little bit about having this experience making you rank an institution lower. So it might impact your coming to that institution, being matching to the institution. What happens if you've matched and you've had these experiences? What happens when that new intern, new resident comes on board as they enter the doors?
And I can answer this and talk about, this is more than just about recruitment and the desire to have diverse ranks, but this is a very vulnerable student, a very vulnerable trainee who's going through a difficult process of having to decide what program will train them best for their career. And they're having to implant this additional task and this additional tax that concerns that they don't feel comfortable based on the color of their skin. So I think it's definitely even more harmful if the trainee does still happen to be coming to that institution. And it also sheds light on the fact that microaggressions don't stop on interview day, or the defense of microaggressions, and having to constantly reevaluate how we're making people comfortable within our space and within their work environment, especially the most vulnerable people, such as medical students and our trainees.
Thank you. Just another question along those lines, because you've talked about it, and I've looked at some of the questions. For those who are listening on this webinar, chat is not available, but the Q&A is. And there's questions come up in a couple of ways, but talks about how we might support. They're asking sort of our residents and others in this space, or our medical students, how might we support individuals during this time? Dr. Landry's already said we can't offer therapy, but what are the things that we might do to support individuals?
I can start. So I guess one of the key things is kind of validating their experiences, because I've often noticed that when someone comes up to the person in leadership with their experiences, they try to dismiss it. It's like, oh, are you sure that's what happened? Are you sure you didn't misread the situation? So first validating their experiences and kind of reaffirm that they shouldn't have felt like that, or that shouldn't have happened. And then also kind of providing resources, like if there is a place for them to go to kind of report this, because I feel like these incidents should be reported, because that's the only way to kind of actually make changes in a lot of these institutions, by having data, unfortunately. So the more it's reported, the more we can kind of come together and kind of address these issues head on. So.
Yeah, I would add similarly, the avoidance of minimalization, minimizing the commentary is so crucial. I mean, I've seen, and potentially I could have done it to someone else, but I've seen my trainees comment about something that was said to them or done to them, and the first immediate response is they probably didn't mean it, that person's a really good guy or a really good girl. And so I doubt they meant to hurt you. And that's sort of how the conversation goes on from that, is trying to convince the victim that the other person is actually really amazing. And it sort of makes that person feel like they're exaggerating their response, or that their response is not appropriate. And I agree with what Dr. Tugo is saying, is that really all our job is just to listen and to believe at the very least that that person's experience happened to them and that their emotions are real. And anything beyond that, I think, is great when it comes to addressing it in a forward-thinking way, so just collecting data, seeing where the trends are. I think one of the most unfortunate parts about residency interviews is that there's not really a way to get feedback like the day of. We're all so nervous that we can be tracked, and that, you know, if we speak up, that's going to affect our rank list. So a lot of the survey data is collected many months later, and people might not remember all the small details of what exactly happened. And so we mentioned actually in our paper, it'd be really nice to have some sort of a national registry or database where people can comment in real time about a particular program's experience. And that is how we can sort of build trends in real time, because of that delay, that, you know, you're going to have some lapse of memory and all the details. And so that underreporting allows these negative influences to sort of self-propagate.
Another question that's come up, but it relates to this, and part of this was about how we help the victim, as you put it, and things that we might do in that space. I have two questions along those lines. Are there ways in which programs, or you talked about maybe having introductions or meeting some of the other Black faculty, becoming aware of, say, minority offices or other kinds of things? Are there things that programs can do to help introduce applicants, interviewees to the broader environment, to the culture, to other opportunities or resources that might be available? And is there a value to doing that? And then the second question I want to put out for any of you is around how does the interviewer become more self-aware? Are there things that could be done to help make the interviewers more self-aware?
So I'll tackle the first question and leave the much harder question to my other panelists. But I think 100% it matters to have this information up front and available. I know there's been a scramble, to have this information available, and I think we're recognizing the importance of being upfront and honest about our diversity and inclusion efforts, talking about belonging, helping students feel like this is a safe space for them to learn as they transition from medical student to trainee. I think all of that is important, and you can do that in the form of one of the things that we've been doing in our office, Dr. Reed, as you know, is having videos available and presenting, doing webinars and having discussions where folks can come and be in a space where they can ask those questions that may not necessarily typically jive with the typical interview questions or responses from applicants. I think it's really important to engage trainees from diverse backgrounds and as well as faculty in the interview process. It's really helpful, as Dr. Landry was mentioning, for those lived experiences to be shared with for applicants, so that they can maybe see, is this a place where I'm actually going to be comfortable? I've had this experience in my undergraduate medical education. Will it continue on at the GME level? So I think having those conversations are important. I think the one thing that we have to recognize is we have to minimize the minority tax that we may be putting on those minority, those Black and brown faculty and those trainees that are already there. And are we adding on to additional work for them that they may not, that we're not necessarily asking our other colleagues to do? But yes, to get back to the heart of your question, have this information up front. All program directors should be talking about their diversity and inclusion efforts as part of their introduction to their program. I think that if you are genuine in this space, you need to be upfront about where you are, what steps you're doing to become more diverse, and where you ultimately want to be. And I think engaging faculty, trainees is really important, because they can help share those lived experiences. And I don't necessarily need to interview all Black applicants that come to my residency program, but it's helpful for them to know that there are Black and Latinx faculty that are available for them to have a conversation with, even if it's outside. And that honestly may be a space where those more honest questions may come about, that the applicant may be reticent to ask a program director because of that fear of being judged, or that fear of maybe overstepping their bounds, when it's a really important question that they may need to ask.
So Dr. Landry has put this out to the other three of you. in terms of how do you become more self-aware. But another question that came in with the Q&A is, one was around how do I become more self-aware? The second one was around, I've been told I've committed microaggressions. What do I do?
I think first and foremost, I think having an open ear and being open and receptive to the criticism, or which should be constructive. I think we need to dismantle some of the fear behind being labeled a perpetrator of a microaggression, and or even participating in something that could be deemed racist, and just allow ourselves to find additional ways in which we can make the environment more inclusive of everybody involved. And so I think if someone says that you've committed a microaggression, it's most likely has happened to all of us, even in this discussion. I think first and foremost, you just acknowledge and apologize, and then understand how you could potentially make amends or corrections in your activities or speech to avoid it in the future. I think just being constructive and realizing that this isn't going to be a quick one-day solution or one course solution. This is going to be every day we're having to learn how to be more inclusive in our environment.
Yeah, in addition to, sorry.
No, go ahead.
Okay, in addition to what Dr. Ellis was saying, I think it's important for us to recognize what identities we bring to the table, because we all have different identities and multiple intersections, and then realizing what privileges we also have. I think that's kind of the best way to kind of like come to the table and realize how we might, microaggressions might affect us and how we might affect other individuals with other different microaggressions.
So with that, I'm going to give you this question that's here because it's perfect for you, Dr. Ochugo. For you, it says, how have you navigated microaggressions surrounding your name and origin? It's from an attendee who's Nigerian, and they're asking how they can prepare themselves.
Yeah, it just depends. I kind of come from a place where I try to take everyone with the best intent possible. But that being said, I've had times where people have said things to me that I did not like they've asked me what my name meant, and then they make a face, and then I had to kind of like realize like this isn't the most appropriate time for me to actually address it. And I go up to someone else, like whether or not there's like someone more senior in leadership, and tell them what happened. Because oftentimes when you tell that person and they're making a face to begin with, they're not gonna be very receptive to you making a suggestion or saying that that was inappropriate. So sometimes going up to individuals higher up on the scale and telling them what had occurred, and that's probably the best way to deal with that. So.
It's interesting because as you talk about that, I also think about the times when we make assumptions about the look that people have or how they're acting. And sometimes it's for other reasons. And sometimes because we're hesitant to ask, we're afraid of what might happen with that. We never find out that something else is going on. They might have been inattentive or for other kinds of reasons. And so where Dr. Ellis is talking about I interpret part of what he said about how do we address a culture where we can have conversations and feel safe in having conversations and raising issues without feeling like the finger is going to be pointed, I think is critical, which to me then comes around. We talked a little bit about what the individual interviewer does or the interviewee and having vehicles for reporting or other things. Does the department or institution have a responsibility in this? Some of you are deeply involved in training programs. What is the responsibility of programs? Departments?
So I think we have two responses that are possible. One is to walk away and to minimize. Unfortunately, that probably does happen more than we would like to see. The other is to really lean into the opportunity, and I hate to use that phrase because I know it's overused, but to really lean into the opportunity and figure out where are my knowledge gaps and how do I solve them? And there are different ways of doing that. One is to reach out to other experts within our department or surrounding departments and lean on their expertise in a way that is going to be beneficial to them. They can share their knowledge. They can help sort of create a shared common language. I mean, we haven't really mentioned the struggle of words, but I think a lot of this is tough because it's really a new language for folks. And many of us feel uncomfortable about saying the wrong thing. Even if our heart is in the correct space, we're afraid that we might use the wrong word or the wrong phrase. And so really teaching others about language and what are the appropriate words to use and timing of those words is a great skill set. And some of us might not be experts in that area. So really calling upon those who are skilled. But it's important to not assume that just because someone is a Black physician or a Black faculty member, they are an expert in this space. Many times I get reached out to by folks inviting me to come give them a health equity lecture. I am not an expert in health equity. I don't do any health equity work for the most part, other than taking care of patients with compassion and grace, hopefully across the board. But beyond that, I'm not a health equity expert. So we should really be careful about not assuming that someone has, just because they have a lived experience, they're at the point where they can share their experience with us, with that sophistication and that expertise. But I do think that it's important for departments to really lean into it as a learning opportunity and to recognize that it's going to be very challenging to understand the language, to understand the culture, to understand how to be sympathetic and empathetic. All of these things are going to take time. And a lot of this is not really a revolution, but more of an evolution. It's going to be very slow and gradual for us to see change and progress, especially in 2020. I think we've seen a lot of shift in our language and how we treat people, but even still, for many of us, it feels so slow. I think it's because we're expecting a revolution where this is really going to evolve over time.
It took us a long time to be here. It's going to take us a long time to move away. But you talk about 2020. And with that, I want to talk to the other Dr. Landry. And during this time of pandemic, many of our programs have moved to a recruitment process online with virtual interviews and potential or not having second looks. Can you talk a little bit about what COVID has meant and moving to this virtual space?
Well, I think one of the first things we have to recognize is students are very uncomfortable, right? And they're in a process where they were expecting one form of an application season for residency, and they're getting something vastly different. Then we also have to recognize this variability that's happening between different programs. And as much as we may be trying to standardize what our efforts may be in a specialty, some students are having mixed experiences. Also complicated by the fact that there isn't any in-person interaction with faculty, seeing hospitals engaging with the trainees that are there and the faculty that are there is leading to students really having to make a lot of decisions with potentially limited amount of information. And then we compound it with everything else that we're talking about here, especially the bias that often happens in these situations. And the reality is the bias isn't going to go away. A lot of people are hypothetically saying, oh, bias may be eliminated because we have, fewer interactions with individuals and we're going to see them in different framing and lighting and so on and so forth. But all of those biases that we're discussing now are not going to go away. We're not going to stop judging people by their hair, their accent, or the way they pronounce their name. Those biases are going to be present. We're not going to stop judging people by their backgrounds either. And I'm looking at the four of your backgrounds that you all have, and they're all varied, right? We have art, we have, flowers, we have a virtual background, but that matters. And what we're seeing in these different backgrounds can determine how we feel about people. Not everybody's going to have the same resources to be in a space where they have a private room where they can do their interviews. They may be back at home with their parents, or they may be in, some sort of shared space, or they may have rented a private office for this. And so what I would encourage programs to do is think about how their bias is going to play out, even in something as simple as what are they looking at behind the applicant.
So one of the questions in the Q&A was about just that interview process. And one of the questions asked about, should they have potentially days where you interview, specific days for interviewing underrepresented minority? And they are sort of all brought in the same day. Does it alleviate tokenism? Does it promote tokenism?
There's actually some good literature to support the decision to do this, and that's to have more than one minority applicant on the same day. And what they found is that it actually is encountering to the Rooney Rule, which is based off an NFL coach rule in which they wanted to hire more than one African American. Every team had to interview at least one African American applicant for the head coach job. And what they found is it didn't increase diversity at all. In fact, it hindered it. But as soon as you include more than one applicant in the interview process, you actually greatly increase your ability to recruit. And I think it has a lot to do with challenging the notion of tokenism, the imposter syndrome, some of the more complex terms like stereotype threat and things that we mentioned in this article. And so I think there's literature to support that having a diverse recruitment day in which you have more than one minority applicant present on the same day would help with the interview process. not just in terms of recruitment, but just creating a comfortable environment for our applicants.
Absolutely. There's another question within here that talks about, they call it the halo effect. It's the flip side of the imposter syndrome. And it is not applying negative unconscious bias, but setting expectations for minorities to be superstars. And maybe someone could speak to that in terms of this sense. The way I would put that question is for me, and I grew up a long time ago, but I grew up in a family where they said it's not going to be good enough to be as good as, you need to be better than, as a Black woman. And so this idea of having to be a superstar and what that can do in terms of this imposter syndrome and other things.
I mean, I think I've seen this within certain demographic groups as a trend more than others, where folks are called model minorities or seen as going to be excellent test takers or really great at science and math. And that causes a lot of pressure for folks, and they start to feel actually in many ways an imposter syndrome, but from a different angle as you're describing. And so I think that also has harm, and we have to really be just careful about the expectations that we have on others just in general, whether or not they're positive or negative, or if they're outwardly displayed or inwardly displayed. We just have to be careful as far as what sort of preconceived notions we have for anyone who's sitting across from, I guess now in the virtual world, but sitting across from our screen and we're talking to. What sort of expectations are we unfairly placed on someone who we don't know their background, what their social upbringing was like, what sort of internal struggles they might have, just in general, with the idea of success and how they, really try to digest their own success. We just have to be very careful with how we place expectations on others.
For everything from to excel or to not excel, or why you got there or why you didn't get there. Or for me, it's being asked, what do all women think? Or what do all Blacks think? And thinking that I can speak for an entire race or entire gender or those kinds of things. There's another question in this that is really more around, comes back to people asking, some of why you're interviewing people is because they have stories that are so compelling. When you read the statements from individuals, such compelling stories, and they're asking how to walk this line between not calling out some of the kinds of things that were said here, and at the same time, being able to speak to some of what might be in people's culture, their family, their other parts of the background that are sometimes pretty remarkable, and asking for some advice about how to get that balance.
So I think this is a tough question, partly because medicine loves trauma, for lack of a better term. I think that there are, we love to look at for these individuals who have made it in spite of. And, we look at these individuals as like, oh, they've overcome so much. They have to be amazing people. And it makes it sometimes really hard to be average and just have, a normal upbringing and whatnot. And so I think we need to just quit looking at people as their stories that they're presenting in their personal statements and look at the other details that may be affixed to the application, whether it's those comments that come in letters of recommendation or their lived experiences outside of that personal statement with the work that they do or the organizations that they engage in, because I think that's when you really get to see the individual come forward. So we got to stop picking and choosing specific stories to highlight within these individuals and get to know them. And I think what that requires is something that I guess we may not be wanting to invest the time to do, which is read the whole application. There's a reason why this term holistic review has become so popular, but also a little bit controversial, is because, well, shouldn't we have been doing this in the first place? And the answer is, unfortunately, we haven't. We've been either screening because we look at numbers, or we look at scores, or we look at institutions that an individual may be coming from, or we look at the very end for the really, really deep, traumatic, personal stories that we want to say, oh, let's bring this person in because they're so amazing because of what they've overcome. And we forget to do, which is actually a best practice, is to read the entire application, get to know the applicant, think about what we are trying to build within our programs. And does this individual bring something that will be additive to our program, and not just trying to make sure that this person will be a quote unquote good fit for our program.
Thank you. I want to, because the questions are here, And Dr. Ellis, there's specific requests for you to share some of the literature. I'm going to ask all who are listening in to refer you to the article, which is superb, and the references within that article. But also, while I have the four of you here, to say, if you would share with us some other references, we can also put them up on our website along with this recording for people who want more information. But they're specifically asking Dr. Ellis for more information. And where they could go for that. There's a question here because there's a desire to go a little bit further into this issue around tokenism. And is it okay to want an applicant to match because they are a minority and not to be tokenism? And so I think people are trying to understand this balance in terms of wanting to increase diversity and inclusion and it not being a token.
I think that was it is certainly difficult to distinguish between the two. I think it more so has to do with how you foster and support that diversity and inclusion once you get it. And so certainly in both situations, you are asking for an applicant to come and you are prioritizing creating a diverse environment in your residency. However, on the other end, with just specifically to just wanting to not include them as a token, you would have to then include resources, make sure that they have part of the culture, make sure they're very much accommodated and that the mission continues past them as well in terms of creating diversity, as opposed to just stopping right when they get through the interview process and are recruited to your institution.
You know, it's interesting because I think this issue around culture is so very important in providing the resources and the supports and how they come into the culture. But the other part that happens as you get more diversity is you actually change the culture too. And so how does that happen? So it's not just about how does this person come in and fit in, but how do we actually change the culture such that more people can thrive in the culture that we have? Along these issues of culture, there's some questions here, and I want to go back again to you, Dr. Landry, about what we should be thinking about in terms of our programs as we're recruiting. And it's a question about Boston. And some of it may be for people who are here from Boston, but from across the country, you'll often hear, we would if we could, we'd recruit if we could, we'd do better if we could, but it's the environment, it's the city, it's these other kinds of things. Can you speak to that and speak to what programs might do to address some of these issues about the myths and some not myths, some of the facts of living in certain places?
Yeah, so I'm a transplant from California through New York City. And when I was in New York City, I definitely heard a lot of the stereotypes and the reputations that sort of were swarming around about Boston and it being an unfit city for persons of color and unwelcoming as well. But I've lived in a lot of major cities. I lived in Los Angeles, I've lived in the Bay Area, New York City, and Boston. And in many ways, they all sort of have the same struggle of there are lots of different people. Some people get along with each other and some people don't, but Boston definitely has a harder reputation than the other three, even though I experienced racism at work very regularly when I was in New York City as well. I think the harder part about Boston is that in the professional environment, there isn't, the numbers aren't so high that we feel like, well, if I come here, it'll be okay, because even if externally within the city I don't have a family, at least at work I do. And so I think that was the hardest part when I transitioned here, was because I came into a department where I was at the time the only Black woman faculty member. And so that was a big transition for me. When I was in residency, out of 15 people, we only had one white man. And so you can imagine that it was a very different culture, because even if there was something that happened in the streets of New York City, I felt like I had my family. We all had very different experiences of being persons of color, of being immigrants, of being first generation. So we could always come together on that. But where I hesitated with moving to Boston, and I ultimately still did, was that I felt like the reputation within the walls of academia were actually much more intimidating than what was happening within the city. And so I think you know, what we try to do now in our residency is really bring forward the culture of acceptance within our program. We really try to highlight what are the things that we're working on, but what are also the things that are going really well within our program. You cannot control the city. There's no way as a residency program or as a department, you're going to be able to eliminate racism or discrimination within the city. But you can try to make sure that even if that's happening within the city, within the walls of your department, within your program, you're able to create a familial environment and a safe space from that standpoint. And really trying to highlight that aspect can really help with recruitment.
And I would say, I'm sorry, Dr. Reed. I would say I
I'm
came
coming to you, so that was perfect.
I had a little bit of a different perspective than Dr. Landry. Both Dr. Ellis and I are from Texas. And so there's a whole different level of racism that you get when you're coming from the deep South and from Texas. I went to med school in Alabama. And so when I came to Boston, you know, people were like, oh, Boston's racist. I was like, I went to med school in Alabama. You know, that's a hotbed of racism right there at that time. And so my perspective was racism is omnipresent. It's unfortunately just woven into America. And, you know, there's different ways that is expressed, you know, where and how you may feel it, you know, whereas you're not necessarily going to see a Confederate flag or someone calling you the N-word, you know, here in Boston, but you may not ever be invited into their home for a meal. So it's just a very different perspective on how racism is expressed up here. That being said, I think it's really important for us to make sure that what Dr. Landry was saying was that our trainees feel welcome and supported within the hospital, that we support them when issues that do happen with patient-doctor interactions occur, that we are building them up and saying, this is not right. We will work to support you. We will be those active anti-racists. We will not be bystanders and be passive in this, but we will be proactive in this space. So I think it's really important as we are inviting our applicants up here, we talk about what we're doing to move towards, you know, and again, because we use a lot of terms, you know, equity, inclusion, belonging, anti-racist. First, having standard definitions within our department for these terms is going to be important, but then really having efforts that are in place to support the applicants when they're here and the trainees when they ultimately come are going to be really important. So utilizing resources that come out of the DICP when it comes to unconscious bias training, anti-racist work, thinking about what your hospitals are already doing. I know all of the Harvard affiliated teaching hospitals from either the GME space, the DIOs are engaged in sort of anti-racist work. How are we making sure that that work trickles down into the residency programs? Our faculty are all involved. And then making sure that students who are applying to our program know that this work is in place so that they know from day one, when I walk onto the campus as, you know, an intern, I'm going to be supported by my faculty, my program director, and my hospital.
One of the things that comes up, it's in the Q&A, but it occurred to me as you were all talking, because you're all connected. You're not all in the same institution. And you talked a little bit about making these connections within your department. But there's also a larger Harvard community across institutions and across departments. Can you talk a little bit about building community within community and community that crosses institutions, and maybe some of the kinds of efforts or other things that might be going on to build that sense of community, but also some of the work that's been done, Dr. Landry, with you and Susan Laguerre and some others in terms of building connections to the outside community and what's available in the outside community.
I can speak to within the community in the hospital setting. I think a big part of the reason I'm part of this group, and even at Beth Israel Deaconess and Harvard, is because of the mentorship opportunities that were available. And so I think fostering an environment where you have access to mentors, especially if you're an underrepresented minority, mentors that also may have walked a similar path as you, is going to be a great resource in terms of making sure people feel comfortable. And also to make sure that there's a fostered community. So I would highlight the ability and support in terms of promotion or professional support, those who engage inside mentorship. And if those are who are entering into a program and looking for ways in which they can find and foster the community, I think mentorship is the quickest way to do so, and to allow yourself to be a mentee to somebody who's walked similar steps to you before.
Thank you. We're almost at the close. Any closing comments from each one of you? A passing pearl Dr. Ellis?
It's been such an honor. I think if everyone just continues to try, I love the social political context that we're in the prioritization of this stuff, but I think the effort, if it can just continue and keep working toward a better goal and not just make this a one-time stop thing, but we're developing an integrated society and an integrated professional realm, and we're trying to make amends to the patient disparities. That's the ultimate end of the goal. And so, yeah, just keep working at it, keep being part of the solution and being brainstorming in ways which we can improve ourselves.
And stay awake.
Yeah.
Stay awake. Dr. Otuka?
Yeah, I think an important thing, which Dr. Ellis mentioned, is to kind of continue to keep doing the work. There's a lot that needs to be done, and it doesn't end today. And we still have so much more that we need to do. So,
Thank you. Dr. Adira Landry?
Well, first, thank you for having us on, Dr. Reed. This has been a really great experience and a nice continuation. And this is a perfect example of what Dr. Ellis and Dr. Tugo is saying as far as keeping the conversation going. We could have stopped at the point of publication of the article, but we felt like this is a nice way to keep the conversation going and allowing you all to interact with us and ask questions. And so as you do your work, try to keep the conversation going so that people can further see what it is that you're doing and what it is that you're working on, and you can spread your good purpose.
And Dr. Landry, Dr. Alden Landry.
Yeah, I think my co-panelist said it best in that this is an ongoing work, and we can't make this a one-time effort and think that the solutions are going to be created and we're going to move into this utopia. We have to institutionalize this work, making sure that we think about diversity, equity, inclusion, and belonging at every step. It becomes a part of the fabric of our residency programs, our departments, our hospitals, and we put forth the structural changes that are needed in order to make sure that this work continues. And that includes supporting individuals so that this work will move forward. And if you don't get a win this year in making a difference in your UIM applicant and trainee pool, that doesn't mean you stop. This is going to take time. This is a marathon.
I want to thank you. I want to thank all four of you. I want to thank you for the article that you wrote. And in the chat, you can actually find the link to the article for those of you who'd like to read it, who have not read it yet. I want to thank you for saying publicly what we often talk about behind closed doors or talk about to ourselves, and for sharing it, and for sharing it in ways that hopefully people can listen and think about how they can change programs, how they can change their behaviors and their actions, so that we can actually move from saying that we want diversity and inclusion, belonging, and that we want to be anti-racist, to actually having diversity, inclusion, and belonging, and being anti-racist organizations. Thank you for your bravery. I thank you for sharing your personal stories. It makes a difference. It makes it so much easier for the person coming behind when they've heard the authenticity of people who are saying, this is what I experienced and I survived and I thrived and I'm here. And I think all four of you are examples of that. So thank you. Thank you for your article. Thank you for being here. There is a poll at the end of this session. For those of you who are here, please take a few moments, it's not even a minute, to answer those poll questions. And again, thank you to all of you. Thank you.